reading out the checklist for emergency vaginal breech delivery. It goes with a mnemonic called CAREFUL. C stands for checking for the presenting part, that is determining whether it is an extended breech or a flexed breech. The second point is to assess the cervical dilatation if it is full by passing the index finger all around the presenting part, that is the breech. When you are passing the fingers simultaneously, you also rule out that no part of the cord is felt between the presenting part and the maternal pelvis. A stands for asking for help. The personnel which are required to help is one person to give a suprapubic pressure, one person to get the episiotomy tray and the delivery tray, one person to inform the OR team and the neonatologist, one person to as a scribe. A also stands for awaiting till the umbilicus of the baby is delivered, that is no touch of the baby is followed till the umbilicus is delivered. R stands for rotating the arms by 90 degrees only if required. E stands for entering the maneuver. There is a martially smelly weird maneuver. This is used for the delivery of the after coming head in breech. F stands for flexing the head by the assistant has to give the suprapubic pressure. U stands for back of the baby being up all throughout. L stands for lifting the baby onto the mother's abdomen.
This is a demonstration of emergency vaginal breech delivery. This goes by the mnemonic CAREFUL. C stands for checking for the presenting part. So now I'm checking the presenting part, which is an extended breech in this case. Here the bitrochanteric diameter is in the anterior posterior diameter of the maternal pelvis with the sacrum towards maternal right. And now I'm checking for the dilatation by passing finger between the presenting part and the maternal pelvis. It is fully dilated and there is no cord between the maternal pelvis and the presenting part. Thank you.
I am Dr. Kavya. I am here to give suprapubic pressure when required.
Thank you, Dr. Kavya.
I am Dr. Kirti. I'll help you with episiotomy tray and delivery tray.
Thank you, Dr. Kirti.
I am Dr. Sabha. I'll call the OR team and neonatologist.
Thank you, Dr. Sabha.
I am Dr. Chandrika and I will scribe the time.
Thank you, Dr. Chandralekha.
I am Dr. Niharika. I am the neonatologist already here.
Thank you, Dr. Niharika.
I am Dr. Malti here, senior consultant. I am there on duty. If any help is required, please inform me.
Thank you, Dr. Malti, ma'am.
Welcome.
Now, mother is brought to the edge of the table in such a way that her buttocks are overhanging the edge of the table. Now we can see the posterior buttock distending the perineum, which is called climbing of the breech. Nursing officer Kirti, can you help the mother to put the legs in the lithotomy position?
Yes, I'll help the mother to put her legs in lithotomy position.
Thank you. This step of mother coming to the edge of the table with maternal buttocks overhanging the edge of the table helps the baby to hang on its own weight. Thank you. A also stands for await till umbilicus. So we follow a no-touch technique here till the umbilicus is delivered.
Yeah, good, Dr. Grishma. You're right in saying that no touch. Actually, it means no hands off till the baby is delivered till umbilicus.
Yes,
so, why do you think hands should be off till the baby delivers up to the umbilicus?
We should allow the baby to deliver on its own weight, ma'am, by gravity. There may be, if we pull with our hands, there may be a traction and there's a cord there. It might get compressed. So we'll prefer to follow a no-touch technique.
Yeah, Dr. Grishma, you're partly right in saying that the no-touch technique is important because unnecessary traction by the person who is delivering can happen. That will lead to extension of the arms and extension of the head. Fine, that is right. Another thing you said, gravity. Now we don't require any gravity, Dr. Grishma. So it is not meant to prevent any gravitational forces to come in play now. The no touch or the hands off technique is followed mainly to avoid unnecessary traction, which will cause extension of the arms and the aftercoming head. Is that clear, Dr. Grishma?
Yes, ma'am. Thank you, ma'am.
Yeah, Dr. Grishma, can you just tell me the anatomical relations? Now you see the anterior buttock, you see the anus, you see the posterior buttock of the baby. The relationship and the procedures you would like to do in relation to these anatomical landmarks. 1, 2, 3. Can you just explain, Dr. Grishma?
I don't know, ma'am.
It's okay, that's okay. See, I'll explain to you, okay?
Yes, ma'am.
So this is the anterior buttock. When the anatomical landmark, the anterior buttock is seen at the vulval outlet, this is the first structure we see under the symphysis pubis, right?
Yes.
At this point, the mother is asked to come to the edge of the table, right? And then the second point is when you see the anterior buttock, that is the point when you give the local xylocaine infiltration at the site of plant site of episiotomy.
Yes, ma'am.
Is that right? You understood the importance of this anatomical landmark and what has to be done? One is?
We'll ask the mother to come over the edge of the table with the thighs
Exactly.
overhanging the edge. And then we'll infiltrate the lignocaine in the plant site of episiotomy.
Yes, these are two things when you do in relation to the anterior buttock of the baby. And when you see the bead of meconium, because the baby gets compressed, the abdomen gets compressed, and then you see a bead of meconium coming through the anal orifice. That is the point where you understand that mother may need an episiotomy. So here you have given an infiltration. At this point, you will actually give a episiotomy, right?
Yes, ma'am.
Yeah. Now the third is the posterior buttock. This is the point where the mother is brought beyond the edge of the table and she's put in lithotomy position. So this episiotomy, the purpose of this episiotomy, can you explain? Did you understand the three anatomical positions and its relationship? Can you just explain again?
Yes, ma'am. First, when we see the anterior buttock under the pubic symphysis, we will ask the mother to come over to the edge of the table, and then we'll give a lignocaine infiltration at the plant site of episiotomy.
Very right.
When we see the bead of meconium through the anus, that is where we give an episiotomy. And then now relation with the posterior buttock is, when we see the posterior buttock, we'll ask the maternal, we'll ask the mother to have the both thighs overhanging, and then we put the patient onto the lithotomy position.
So when the posterior buttock is seen, we ask the mother, we help the mother in such a way the buttocks are overhanging the edge of the table. You can see the table edges here, the buttocks are overhanging at least 1 inch by 1 inch. That is the thing we do, and put her in the lithotomy position. So
Yes,
now
ma'am.
you understood. Okay?
Yes, ma'am.
Yeah, Dr. Grishma, another relevant question I feel that you should know is, we have given an episiotomy. This is mainly to facilitate the posterior buttock to get released, the climbing of the breech. So, when compared to shoulder dystocia, where there also we give a episiotomy, right? So, in comparison to shoulder dystocia, can you tell me the purpose of this episiotomy in a breech delivery? Yeah, Dr. Grishma, see, we have a soft tissue obstruction. The anterior buttock is released below the symphysis pubis, but there is a resistance offered by the maternal perineum. So this is soft tissue obstruction for the posterior buttock. So that has to be released. For that purpose, we give an episiotomy. So the climbing of the breech happens only when we give a cut, especially in a primary. Sometimes in a multi it is not required. Okay. The second point is, see, when you recall the mnemonic careful, E stands for enter the maneuver. That is the Mauritius smelly beard. So
Yes.
you will have to enter, isn't it? It facilitates to enter the maneuver also. And the third thing is, it gives some space for the aftercoming head.
Yes, ma'am.
So did you understand why?
Yes, ma'am.
Yeah.
Thank you, ma'am. So here episiotomy helps in delivering the posterior buttock, wherein the perineum is offering resistance causing soft tissue obstruction,
Very right.
and also it helps in facilitating the enter maneuver, where we insert our 2 fingers into the vagina for facilitating the flexion of the head by putting the fingers onto the upper jaw of the face, and it also helps in facilitating the delivery of the aftercoming head of the baby.
Yeah, very nicely you have explained. It's a soft tissue obstruction. One, it helps in the release of the posterior buttock. Second, enter the maneuver, that is a Mauritius smelly beard, where your fingers have to reach the maxilla of the facial bones of the baby,
Yes, ma'am.
isn't it? So it facilitates, it gives you some space. And the third is facilitates delivery of the aftercoming head. Very nicely explained.
Thank you, ma'am.
Yeah.
The baby is being delivered till umbilicus now.
Yeah. So it has delivered by the hands-off technique till the umbilicus. Now what are you supposed to do, Dr. Grishma?
I have to put a piece of cord aside to prevent the compression, ma'am.
A loop of cord. So you just take out a loop of cord and then just pull it and keep it aside. Why are you doing this, Dr. Grishma?
To avoid compression of the cord, ma'am, while delivering the baby.
Yeah, you're right. But where does the compression happen, Dr. Grishma?
When we deliver the aftercoming head, it can...
So it gets compressed between the fetal head and the maternal pelvic
Pelvis.
brim.
Yes.
So that is little dangerous. So we have a tick time and we have a scribe person who has to help us to tell the time interval from the umbilicus to the delivery of the head. How much time do you think we can allow safely for the baby to deliver from the umbilicus to the head, Dr. Grishma?
It's 5 minutes, ma'am.
Exactly. And from the for the head delivery?
It's only 2
After the
minutes
shoulder?
after the shoulder delivery, ma'am.
Exactly, 2 to 3 minutes from the shoulder delivery. You're right. So now, are you happy with this position of the baby?
No, ma'am.
Why?
I want the back to be anterior.
Yes, it is anterior. Back is anterior. Back is up. So how do you hold the baby now? What is the position, safe position to hold the baby, Dr. Grishma?
With a finger in between both the angles, ma'am.
No, it is not like that. The femoropelvic grip. So you have to pass like a girdle. Pass your index finger around the pelvic girdle and keep your thumbs parallel to the to the sacral bone,
Yes, ma'am.
spine. Okay, so you're using your index finger to grasp the iliac bones of the baby, and your thumbs are parallel to the fetal spine. All other fingers are you're just holding. Why are you holding the baby in this femoropelvic grip, Dr. Grishma?
To deliver the baby until the shoulders, ma'am.
No, we hold the baby in this position because we do not want to injure any of the soft parts, abdominal organs of the baby. So you are using all the bony points. You're not putting any pressure on the
Soft
intra-abdominal contents of the baby. So
Yes,
this
ma'am.
is to avoid injury to the abdominal structures of the baby. Got it?
Yes, ma'am.
Yeah, thank you.
The baby in femoropelvic grip, where my index finger is hooked onto the iliac crest of the baby,
Yes.
and my 2 thumbs are held in parallel position to the fetal spine.
Very right. You're holding the baby in a correct position. It's the femoropelvic grip. This is mainly to prevent injury to the intra-abdominal
Abdominal
structures of the baby. Very right. Now we can see another landmark. We have discussed about the anterior buttock. We have discussed about the bead of meconium. We have discussed about the posterior buttock. Now we see another landmark. That is the
Scapular.
lower angle of the scapula, and then we have also seeing the axillary fold. So based on these anatomical landmarks, that is the scapula, then the axillary fold, can you tell me some important relationships? What is your interpretation at this level, Dr. Grishma?
After seeing the lower end of the scapula, we'll deliver the shoulders of the baby.
Yes.
We'll see if the shoulders are in flexion position. First, we deliver the posterior shoulder and then the anterior shoulder. By, if needed, by rotating the baby to 90 degrees.
Right. So you're partly right, Dr. Grishma. See, when you see the angle of the scapula and the axillary fold, that is the time when the arms are to be delivered. The time has come for the delivery of the arms, number one. And then the important observation is when both the scapula are parallel, that indicates there is a flexion attitude of the arms inside. If there is a winging of the scapula, it indicates the arms are extended. Nuchal arms. So that is the important relation. So it has told us that it is time for the arms to deliver, number one. Second is the relationship of the arms, whether the attitude of the arms, whether it is in flexed attitude or in an extended attitude. So you'll be happy if both are parallel. You will be unhappy and you'll have to go for another maneuver and intervention when the scapula is winging, which indicates extension of the arms. That is the reason why I never give any traction. Allow the baby to deliver on its own with the maternal efforts and the uterine contraction. Did you get it?
Yes, ma'am. Thank you, ma'am. I can see the axilla and lower end of the scapula. So now I am trying to deliver the deliver the arms of the baby.
Yes, Dr. Grishma. So Dr.
So I am along.
Yeah.
Yes, ma'am.
So what you'll have to do is we should allow the baby arms to be delivered on its own. If it's not delivering, then you go and help for the delivery. But you will have to splint your fingers, Dr. Grishma. Use two fingers. Two fingers. Go along the humerus. Yeah, go along the humerus. Try to reach the elbow.
Yes, ma'am.
Flex it and bring the elbow out.
Reach the elbow.
Yes. Flex it and then the in front of the chest of the baby, and
Yes.
then the arm comes out. So using the fingers along the humerus is important. Exactly. Well done.
Thank you, ma'am. As the posterior arm is not visible, I am rotating the baby to 180 degrees.
See, there is a delay in delivery of the posterior arm. So that is the reason why you are helping out to deliver the posterior arm. Am I right, Dr. Grishma?
Yes, ma'am.
Yeah. So your femoropelvic grip, your index fingers on the pelvic iliac crest or the pelvic girdle. Yeah. Rotate it some more. Yes, till you see the axilla of the baby.
So now I am able to see the axilla. I deliver the posterior shoulder in the same way as I did the anterior one with my two fingers.
You are using those fingers as a
splint, going through the humerus, reaching the elbow.
Going along the humerus.
I have reached the elbow. I am flexing it and delivering the arm.
Yeah. Good job, Dr. Krishna.
And we should always. Now I am allowing the baby to hang on its own weight with using my two hands and supporting the baby at the buttocks.
Yes, exactly.
I do it until the nape of the neck is seen.
Yeah, very right. So you are allowing the baby to hang on its own weight, but at the same time you are supporting the baby. This is important at the region of the buttocks. And then you rightly said you are going to wait till you see the lower hair line. That's the point. That is another anatomical landmark for us to understand that the head has to be delivered. Right?
Yes.
And what do you think is most important? What do you want exactly at this point? What problem do you anticipate for the aftercoming head of the baby, Dr. Grishma?
Yes.
What is that you were anticipating about the aftercoming head, Dr. Grishma?
So we should be careful that there may be an extension of the aftercoming head, ma'am.
Yes.
So to prevent that, I'm not giving any traction to the baby, and just I'm
Right.
allowing the baby to hang on its own weight by just supporting the buttocks.
So by allowing the baby to hang on its own weight, that is facilitating some amount of the descent of the baby, right?
Yes,
By not allowing traction, you're preventing extension of the fetal head. By giving support at the level of the buttocks, you're seeing that the baby suddenly doesn't come out and then there's a fall,
Yes,
right? You understood the purpose of each one of them?
Yes, ma'am.
Thank you.
I can see the lower hairline, so now it's time to deliver the aftercoming head of the baby. With my left forearm, I'm supporting the baby with 2 legs and 2 arms on the either side of my left forearm. And my left hand fingers I inserted into the vagina in such a way that my 2 fingers reach the maxilla of the face to ensure the flexion. The other hand, I'm using 3 fingers, my index and ring finger onto the either of the shoulder and my middle finger onto the suboccipital region to ensure flexion. All these maneuvers are to ensure flexion. So along with these, we also give suprapubic pressure. Dr. Niharika, can you please help me with suprapubic pressure?
Yes, I'm Dr. Niharika. I'm here to give suprapubic pressure.
Thank you, Dr. Niharika.
Lakshmi, please bear with me. We are going to deliver your baby. I'm going to give pressure over your tummy. Is it okay for you?
Okay, ma'am.
I'm giving suprapubic pressure with my base of hand in downward and inward direction.
So now I'm flexing the head of the baby to deliver the baby. I'll do this maneuver until I see the jaw of the baby. So now I can see the jaw coming out. So this is the time to lift the baby onto the maternal abdomen. So I use my fingers, one finger in between the ankles and the index and ring finger on the either side of the ankles, and then I lift the baby onto the maternal abdomen. Congratulations, Lakshmi. We have successfully delivered your baby.
Thank you, ma'am.